Okay, I think we are live onto YouTube, and I have also enabled permissions to share the screen, so we can start. Arti madam.
Super. Can you see my screen?
Yes, yes,
Just give me 1 minute. Yeah, you can see it now.
yes.
Okay, so welcome once again to our brainstorming and learning from case-based scenarios. And we are continuing with the case-based discussion on adenomyosis because there's so many varied presentations, so much to learn from. And the last session, we dwelled into the basics of medical management and surgical management of adenomyosis. And you can go through, those of you who have not watched the previous session can look at the whole video on YouTube. And let's, without wasting further time, start discussing our first case. So Jay, this was a 32-year-old lady, P2L2, completed her family, came to us with history of menorrhagia and severe dysmenorrhea since the last 4 years. And all she took was just painkillers for pain relief. And she does not desire any surgical intervention, at least for a year, as she has other commitments. And she came with some basic reports of her hemoglobin, thyroid. She has no medical issues. And this is what her ultrasound picture showed. A uterine length of 12 centimeters, posterior wall adenomyosis. The posterior myometrial wall was about 6 centimeters in thickness. Anterior myometrial wall was around 1.8 centimeters. So this was a clear-cut case of posterior wall adenomyosis. So now, Jay, over to you. This is the platter of options available to all of us. And I request you to go through all of these options available. What are your takes on it, especially in such a woman who is on the younger side and having an issue and doesn't want to go in for a hysterectomy immediately? So what are your takes on all these options?
Okay, wow. This is like a long question. So, so I think, yeah. So see, one of the most important things which people have to remember as a blanket rule is that whenever a lady presents to you with so much severe adenomyosis where the size of the uterus is more than 10 centimeters, no matter what you do, okay, your medical line of management is going to be ultra temporary. It is really not going to work. Okay, that is just something which you have to keep in your head as a common rule. People may try to do all sorts of gimmicks to reduce the size and volume of the uterus. One can try GnRH agonist depot, Dynogest, combine both of them, ask the patient to bath in them, do a transmyometrial injection of GnRH agonist. Okay, none of them will help in a significant way. But as Aarti madam has said, let's go by each one of them, keeping this case in mind. Okay, 12 centimeter size of uterus with 6.5 centimeter posterior adenomyosis. All right. See, one thing we know that endometrium and myometrium and the junction, all the three things are going to be severely compromised, which causes a very abnormal prostaglandin secretion inside. Okay, and this abnormal prostaglandin secretion itself is enough for somebody to be in some deep trouble. Okay, so tranexamic acid, mefenamic acid combinations, or just tranexamic acid alone practically has just got extremely limited role as far as reducing those clots is concerned, reducing the menorrhagia is concerned. It is going to do virtually nothing to the dysmenorrhea, and if at all it does, then it is going to be just for that 4 to 6 hours. Okay, second option, madam, which you have given is oral contraceptive pills. And oral contraceptive pills, I personally think, okay, when you have a 12 centimeter uterus, okay, and let's say you want to use oral contraceptive pills, it is absolutely incorrect to use, but let's assume you still want to use it. Okay, then in that situation, the best way is to give oral contraceptive pills continuously. Let the lady not get into menses only. Okay, it will not cause menorrhagia, it will not cause dysmenorrhea, but it will not cause any volume reduction also. The only problem which happens with OCP is long-term usage in adenomyosis especially such large uteruses, there will be breakthrough bleeding. So these people will keep on having spotting. The reason being endometrium cavity is enlarged. Actually, the cavity is also enlarged. Okay. It is altered and enlarged, both the things. So now because that typically happens, you are going to be in trouble. All right. Now, Bapre, I think Aarti madam, she loves me, but then she loves Dynogest more. She has written Dynogest 2 times. Okay. So,
Oh, yes, yeah.
that's-
That's how
okay.
much many gynacs love Dynogest, especially for endometriosis and adenomyosis.
No, it is a theory of convenience. See,
Yeah, yeah.
it's like how harmonic is sold to Indians, no? Or use harmonic, no lateral thermal damage. Now harmonic has gone out of equation since sharer has come into the market. Nahin?
Yeah.
Where is that lateral thermal damage with the sharer? Because all this while, all conference which were sponsored by Harmonic and all the live workshops where Harmonic was demonstrated, the surgeons were absolutely told in their head that no matter what happens, you are supposed to promote Harmonic. Nahin? Something like that. See, Dynogest is a beautiful drug. Kindly don't mistake. It's, there is no mistake or there is no doubt in that. Okay. It is a beautiful drug. There is absolutely no question in that. But, okay, it has its indications. We can't really, have you ever heard anybody using Dynogest for extradural hematoma? No, na. That is because it is not indicated in that. Correct. Have we ever heard anybody using transanal Dynogest for treatment of fissure in ano? No. Right. So it is not indicated for that. In the same manner, Dynogest, as wonderful as it is, okay, it is a wonderful progesterone. One can combine this progesterone with estrogen, and you have this 4th generation oral contraceptive pills with Dynogest, which is also absolutely fantastic. But the target of using Dynogest is only one, and that is pain relief. Okay, you cannot use Dynogest for absolutely no other indication. Okay, you cannot counsel your patient that, look, I am a very pathetic surgeon. I don't want to call anybody good to operate, nor do I want to let you go to a good surgeon who can actually do a complete clearance. I want to stay ordinary. Okay, but I want to ensure that you don't leave me and go also. Okay, in that situation, you prescribe Dynogest to the patient by telling the patient that take this and your problem will be solved. Now, God has been extremely kind to Dynogest as well as to surgeons, because there is so much data now available on all social media platforms on something called as Dynogest abuse. And that is something which is a beautiful thing which has been started by some endometriosis people who realized that Dynogest is one of the worst things that can happen to endometriosis. I hope it picks up momentum. If they need any funding, I'm willing to give you funding, guys. Don't worry. Okay, because it is one of the worst things that a patient can have as far as endometriosis and adenomyosis is concerned. They can have it when they want pain relief. This drug doesn't cause volumetric reduction of endometriosis. This drug doesn't cure endometriosis. This drug doesn't reduce the size of adenomyosis. But yes, till you take it, there will be pain relief. Okay. The minute you stop it, your pain will come back as beautiful as it is. Okay. Keep that in mind. So I hope that answers for both the Dynogest. I guess madam wanted to use 2 separate brands of Dynogest, Visan and Dynogest. Okay, so we've answered for both. All right. Letrozole plus norethistron, madam, we discussed this in the last session as well. Uterine size less than 10 centimeters, it will really work beautifully, because you need an anti-estrogen and you need an sort of an anti-progesterone to reduce the volume of the uterus. That is something similar to what GnRH agonist depot does. The only advantage of letrozole plus norethistron is it doesn't cause as severe osteopenia as a prolonged GnRH agonist would cause. At this onset, I would also like to tell all of you that last Thursday we had discussed about a patient with avascular necrosis of the acetobular head following the excellent administration of GnRH agonist, right? She had only taken 6 shots, and which is why she ended up having the avascular necrosis. She has undergone a wonderful surgery. Her hip has been replaced, and she is 26 years old. So we hope that she has a wonderful marriage, okay, and a long life ahead. with an artificial hip. Okay. Now we come to Mirena. Mirena is very good. Again, it is like Dynogest. It is a progesterone. But I personally think, okay, Mirena should be used when the cavity size is less than 10 centimeters. Sorry, the uterine size is less than 10 centimeters. But if you are using Mirena, please add letrozole along with it, like an alternate day letrozole, or or a daily letrozole, or whatever. There is just one thing which I want to mention about daily letrozole that also causes osteoporosis, because there are a lot of estrogen receptors on the bone. So please give calcium add back. Simultaneously, letrozole will also cause the breast to become very flaccid. A lot of young women don't really like it. Okay. And if the women don't really like it, you can give alternate day letrozole 2.5 mg in the night. Okay. Fine. Then we go to TRCE, trans cervical resection for the endometrium. To be honest, TCRE is a wonderful procedure. Okay. But the thing with TCRE is you need to obliterate the entire cavity. Okay. And you need to have something, okay, in the cavity inside in order to ensure that, okay, there is some menses. Otherwise, what happens with TCREs? We've seen people developing pyometra. Okay. After TCRE, when the whole cavity is obliterated and only the cornual endometrium remains. It is like creating iatrogenic bilateral acubes at the cornual end. Even that causes severe pain. So, not a very strong recommendation. I honestly, I am not a guy who reads every stupid article which is published in the journal, but I do not think transcervical resection of endometrium should be used for a 12 centimeter adenomyosis. At least I will not use it. See, I'll give you the indication of TCRE. On an average, we will end up performing close to 150 in a year. All right. It will work the best. Okay. The best when you have a uterus around 8 weeks. Patient is complaining of menorrhagia. There is no severe adenomyosis. Patient wants to conserve the uterus but doesn't want Mirena. Okay. All the words are important. Patient doesn't want Mirena. Uterus size is almost bulky to normal. There is no adenomyosis. And the prime complaint is menorrhagia. And when in menorrhagia you do TCRE, it will work beautifully well. All right.
Right.
At this juncture, no, madam, I want to answer one very important thing. A lot of people do this beautiful show off about doing hysteroscopic adenomyomectomy. Listen, hysteroscopic adenomyomectomy is good when you have that small cystic adenomyoma measuring 1 centimeter, 2 centimeter, causing that mild indentation in the cavity, or causing that little cavity to become irregular. If you end up resecting a 6 centimeter posterior wall adenomyoma through the hysteroscope, okay, you are going to cut through the uterine muscle at so many occasions that the patient is going to go into fluid overload. All right. So please keep that in your head. Kindly don't extrapolate hysteroscopic adenomyomectomy surgeries for such type of horrible indications. Okay. Then comes HIFU and uterine artery embolization. So I'll answer both of them together. Both of them are procedures which actually should be eradicated from the textbook of gynecology. Okay. For any indication. Just to soften the heart of the people, I am myself trained in uterine artery embolization. Okay. I have done 4 so far. I am not an interventional radiologist, but I am trained in doing it, and I have a training from Los Angeles, which is certified. All right. So I know much more about uterine artery embolization than 98% of interventional radiologists. So don't worry about it. Okay. And I'm speaking a lot of sense because you have such a beautiful procedure which is available, which goes by a name called adenomyomectomy. Okay. Uterine artery embolization, no? People who it feels only very good. You are wearing a beautiful lead apron. There is an expensive Philips ka Siam suit inside which you are entering. I'm building that suit in my hospital, so I know it costs you around 4 crore rupees. AMC per year is 27 lakh rupees. So when you build this suit, no, you feel that, oh my God, I want to do uterine artery embolization even for ophthalmology, something like that. But try and understand one thing. One of the only indications for doing uterine artery embolizations or for that matter, interventional radiology in gynecology. And I think the maximum application it is going to find is going to be in site-specific chemotherapy deliveries in secondary metastasis. Okay, in those areas where you can't really go and operate. Okay, or interventional guided, ablative therapies for secondary mets. Okay, so that is the primary indication for using it. But obviously, we are building an institute, so we are going to build it. All right. As far as uterine artery embolization for this is concerned, uh, it's a one-line answer, doesn't merit discussion. It has got no role. Okay, it has got no role. Coming to HIFU. So, once you invest around 16-17 crore rupees in a machine, you are definitely going to speak of that machine as if it is the only machine which cures, it cures adenomyosis even before it is formed, right? But by that logic, people should undergo prophylactic HIFU. Once you cross the age of 40, every year you should have one session of HIFU. But let me tell you, HIFU requires a lot of expertise. You need a fantastic radiologist to exactly locate the adenomyoma or the fibroid. It is a very heat sensitive thing. One wrong move, incorrectly prepared intestines, incorrect patient position. Okay, all these things are going to cause some or the other amount of complications. And obviously, everybody would have done 500 HIFUs in their life, and all those patients would have been completely cured. The reason why you think those people are cured is because those patients have not come back to you for suggesting something like this to them. Okay, so in our career so far, from 2019 to 2022, we have done approximately 4 fistulas, which are predominantly vaginal fistulas connecting to the rectum, or uterine fistulas, large uterine fistulas, which are a result of HIFU. Okay, one of the most important things which one must understand about HIFU is that it will work when you have an excellent serosa. Please keep this in your head. HIFU will work beautifully when there is an excellent serosa available. The biggest problem with adenomyosis is, even if on ultrasound you feel that posterior wall adenomyosis is there, this posterior wall adenomyosis will reach the serosa also of the uterus. Okay, it is not an encapsulated disease like how you have a fibroid. Because it is not an encapsulated disease, okay, HIFU is not going to work extremely well as far as adenomyosis is concerned. Okay, it will not really work well even in fibroids. But in a city where you have intelligent people, you also have donkeys, and you will always get one or the other donkey who will get ready for doing a HIFU, because they are so precarious about doing a surgery, and how these stupid wannabe South Bombay people speak, something like that, and they will end up doing this surgery, end up in a complication, and then run around. So I hope, and I'm so happy that 90% of cities in India don't have HIFU, so that such stupid options are not given to the patients. Okay. We discussed GnRH agonist depot already. Hai na?
Right.
I will discuss adenomyomectomy in the last. Okay.
Right.
For a 32-year-old lady, madam, hysterectomy probably not the best option. Okay. I think 32 years old lady, so I guess, okay, I guess you mentioned she has completed family P2L2.
Correct.
And but she's just 32. See, one thing one has to agree. Okay, a lot of women are sort of very emotionally attached to the uterus. Now this could be a healthy uterus to which they are attached to, or it could be a bad uterus which they are attached to, but they are attached to the uterus, and it's not going to be easy to counsel a 32-year-old for a hysterectomy. And any which ways in India, what happens is 25 women together will take a decision for the hysterectomy of the 26th woman. Right? And none of them are doctors, but all of them have faced complications of hysterectomy. The beauty about women who are not medicos is that they know all complications of all diseases and all surgeries. Okay. So if in your exam you forget to answer the complication of glaucoma surgery, you call up your neighbor who has never done the surgery, they will tell you, Arey, no, one of my cousin auntie's friend's sister, no, her mother's daughter's second cousin's friend had done this surgery somewhere in somewhere in Delhi, and her brother messaged me stating that she had a tremendous earache after glaucoma surgery, so don't do it. So same things will happen to such young girls in India. I practically agree with them. I think we should not do hysterectomies for such young girls because, again, I'm coming to that, because you have such a wonderful surgery which is available, and this wonderful surgery goes by the name of adenomyomectomy. All right.
Right.
Now coming to the final thing, adenomyomectomy. So is it okay? I mean, of course I've not planned for this, but is it okay if I just share screen to
Yeah,
just
yeah, I will, of course.
tell?
Of
I mean,
course, I'll just stop share. Yeah.
I mean, to tell people about like what exactly happens, or what should you keep in mind while doing an adenomyomectomy. Okay, just 1 minute. Right. So just let me know if you can see my screen, huh, Aarti madam?
Yes, we can. You can see your whiteboard.
Yeah, whiteboard, no? You can see my signature, right?
Yes.
Sorry. See, what are we trying to do as far as an adenomyomectomy is concerned? I'll just explain the general principle to you. You have a large uterus like this. As I'm trying to draw the picture which Aarti Garu showed us. So you have a adenomyoma with an endometrium compressing towards the anterior wall, something like this. Okay. So this is one view. Okay, I'll draw the coronal view in a little while. So see, this is how the uterus is going to appear to you from the posterior frame. Okay, when you put your laparoscope inside. So what is important to remember is this point. Can you see this? This adenomyoma extends almost till here. So that means your incision on the posterior wall should go at least till that level of the cervix. Okay. That is one important point. Second, normally you will see this, no, the round ligament is attached somewhere here. Okay. On both the sides. And there is this little jut of endometrium projecting above that. So remember, keep round ligament as your marker. Your anterior incision from here should go in the same plane as the plane where round ligaments are present. All right. So basically what you are going to do, if I draw it in this plane now, your incision will go from here and it will go somewhere till here. Okay. Other very, very important thing. In a lot of adenomyomectomy surgeries, see, fallopian tubes are attached here somewhere. Okay. Posteriorly, when you see fallopian tubes will be attached here. Almost in endometriosis, what will happen is ovary will also be somewhere here. And these fallopian tubes sometimes are bent and attached here and all these things. See, when you cut now, little part of this cavity and little part of this cavity close to the fallopian tube may get compromised. So when you do an adenomyomectomy, you must tell your patient that there is a chance that she will directly need to do IVF after this, because the tubal factor might get compromised, especially at the cornual region. This part will get cut in your cuts, in your debulking which you do. Okay. Now what is important, I think, Aarti madam, we routinely take this consent in Hyderabad, isn't it, when we operate?
Yes.
So this is your adenomyosis as was shown, right? This is the typical that appearance, right, of
fan-shaped appearance.
Yeah, fan-shaped appearance of adenomyosis, right? Something like this is going to be there. Now, please try and understand. If somebody tells you that I will preserve this entire cavity, okay, that's why I am the world's best IVF specialist. Remember, there is going to be some adenomyosis which is going to be present here, which is actually responsible for causing that curvilinear change. Okay, so in adenomyomectomy, a little endometrium will get compromised no matter what you do. Even if you are the best guy on earth, maybe 5 millimeter, 2 millimeter, 3 millimeter, 1 centimeter, some endometrium will get compromised unless you are doing this. See, a lot of people do adenomyomectomy and they say, oh, they post on Instagram, no, I did world's best adenomyomectomy, super, patient went home happy. Now you removed this much. Okay. Obviously, you are 1 kilometer away from the endometrium. Patient will come back. Patient will have pain from next month only. Don't worry about it. Your target is not actually this. Your target is to debulk something like this. This is your target. So now you will say, Are, if you debulk so much, so basically what has happened is now this entire uterus is going to get converted into something. When you cut open everything now, I mean, when you have debulked everything, see what will happen to the uterus. Okay. So I'll draw the uterus to explain it nicely. See, it will become like this. This is where the fundus is. Okay. Then you will have a flap like this of the uterus. Then you will have a flap like this of the uterus. Okay. And inside this, there will be the endometrium here, which you will visualize like this on your laparoscope. Okay. This flap has been emptied till a little part in the anterior, emptied till a little part in the anterior. So what you are supposed to do is you are supposed to close these flaps to each other. So when you attempt closure in this, see, your endometrial cavity will then become slightly elongated as a part of the closure. Okay. And what will happen is this green flap, the first green flap covered it like this. The second green flap went above it. And this part, this fundal flap will then come and overlap this. So this is one technique. Okay. This is one technique which people normally call it to be a triple flap, which allows the maximum debulking. You can have, I mean, if the adenomyosis is not, and I'm talking for this case, I'm talking for this 12 centimeter case provided to us today by Dr. Aarti. You can have a focal adenomyosis where the repair is very straightforward. It was a focal adenomyosis here. You just had a direct repair. Okay. You can have a large globular adenomyosis where the triple flap is not a triple flap. It has become a double flap. Okay. All these variations probably we will explain when we take such a detailed class on what are the different types of what are the different types of flaps which one may expect when he or she is wanting to attempt an adenomyomectomy. But for the current time being, you must just remember this, that this is something which is important, which you need to keep in mind, right? And please remember, once you do a good adenomyomectomy, I do understand. Just remember one rule: if there is adenomyosis on the serosa, okay, that means that part of the serosa also has to get compromised. That part of the serosa has to go. You must remove that part of the serosa, otherwise the patient will have recurrence. I think we have done a hell lot of adenomyomectomies in South India, especially with Dr. Aarti and Dr. Shilpa and Dr. Padma Priya. And what typically happens in all those things is, once you notice, none of these patients are going to come back. And the reason why these patients won't come back to you is because the debulking is so good. In fact, I know 1 or 2 patients have gone and visited Shilpa Madam, and they've actually thanked her that they are experiencing periods without any pain. Imagine they went in front of Shilpa Madam and they thanked me. Though she's so good looking and such a superstar and all these things, those patients went to her, had the courage to thank me in front of her. So imagine how much pain relief would have happened. Right? And this pain relief is your hallmark of a good surgery for adenomyosis. Okay. If the patient has come to you and told you, Sir, Madam, I have such limited pain that I'm very happy, that means your surgery is done nicely. You don't really have to prove and end up proving to anyone that, I do, people write these beautiful things in conferences, do only what is necessary, not too much and not too less. They can't define it. Nobody can define what is too much and what is too less. They just know that something has to be spoken here. Okay. So don't fall for that. I think adenomyomectomy is a great procedure. People have this worry about adenomyomectomy. We've shown adenomyomectomies live so many times. I think if people want to see, they can probably see that, and they'll learn a lot of things. Yeah. So I hope that answers all these questions on the various platter of options. So coming to the platter which I would choose, okay, the answer is simple. The patient deserves an adenomyomectomy. So I'm going to write it on her file. You need to do adenomyomectomy. Kindly come back to me after 1 year. Because just because you want incorrect treatment, I am not going to compromise on my reputation by giving you incorrect treatment. Okay. One more thing I want to tell you, madam. These days, some people are experimenting with that microwave ablative therapy. for adenomyosis. Okay, I think that is something which we missed out. But
Right.
I have honestly, I will be honest, I have not invested in that machine. Okay, it is costing 26 lakh rupees. But if you call for that machine on rent, it is 45,000. Okay, the thing is, no, it comes with this laparoscopic probe inside. So you can put a laparoscopic probe, but I personally think it will work only for focal adenomyosis. It will not work for a size like what you have mentioned. So again, in this case, it will have no role. It will have a role when there is a focal adenomyoma of 3 centimeter without any cystic degeneration. Okay, because for microwave ablation to work, it requires a solid thing which it has to liquefy. It can't really liquefy a liquid, it can't really do that. So I just thought that is something which probably people see. Everybody will be happy with a non-surgical option, right? Patient is happy, doctor is happy. But the good thing about non-surgical options is they don't work. So that is what we must keep in mind, right?
Super, very nice, Jay. I think whatever you mentioned about, your opinion about all these options available, we will not find it in most textbooks, and a very, very wonderful description.
No, I would also like to clarify. I just hate it when people send messages of criticisms to people like Shilpa madam, Aarti madam, Padma Priya madam. You have got guts, no? You send these messages to me. All right. Listen, most of the things which I speak are practically out of experience of seeing and investing in these machines. Okay, and doing these therapies. I don't really, at least till so far, I have not published any papers on it. But I am a KOL for the guys who gets these machines in the country. And when the guys get the machines in the country, no, unfortunately, they come to meet me the first because they want to know my opinion on how these machines will work in the market. And they also know that I have not published anything. Okay. And they will still come. So I personally think if at all, one has to comment, you please send a big thank you messages to these three ladies because they are taking out their time. Everybody is very busy. We understand all that. They are all busy and they are taking out time, and teaching so many things is not that easy. So I think they deserve much more appreciation. And any constructive criticism on mistakes is welcome. But if my t-shirt is blue in color and you think that blue is not similar to dark blue or sky blue, I think it is absolutely fine. So thank you so much. And Aarti madam, I'll hand it over to you.
Jay, after 18 hours of operating, how do you manage to still be this witty?
No, I am, see, honestly, you will not believe this, Aarti madam, because I had not seen the messages since morning. Before I came up, I had called up Shilpa madam just to ask her what was the topic for today, because I had actually not seen that, right? These are things which we do day in and day out, no? So we don't, the intention of doing these classes, I guess, which you had in your mind, was to keep it as practical as possible. This is not like that panel which is conducted in those conferences where every panelist know what question they are going to be asked, and then they experience that shock on the stage. Oh my God, what a question, Are you already knew it 3 weeks back? They had emailed it to you. This was the question, It is not like that, and it is good that people can at least learn from, see, because when you speak like this, you will only end up speaking what you do. Absolutely. And what is the truth. Otherwise, you can't really probably give comments like this, I think. Okay.
I agree. And Jay, I want to add, we had one patient we operated in August with a very similar type of adenomyosis, and she would be admitted every month for management of severe dysmenorrhea. And after the surgery, she's come back, and this is her first period in 8 years where she has not experienced that much of pain. She says her pain score is about 5% compared to what it was in the past. And now those patients who really need adenomyomectomies, she said, please let those patients talk to me because I know how much of pain relief I had after that surgery. So this is just a little testimonial of one of our patients who really benefited from adenomyomectomy.
No, see, that's the beauty of a good adenomyomectomy surgery, madam. The pain relief is unmatchable, So I'm happy she's doing well. You know that lady.
Yes. Now, 1 minute, Jay. We are already about half an hour into the session. I meant this is just another question. Many of our colleagues advise a CA125 and LDH for
Yeah,
patients with adenomyosis.
yeah.
And what is your,
It
take
is
on
good, madam. See,
ultrasound
honestly,
MRI?
yeah. Okay. So I will go from CA125 and LDH. See, CA125 is good to do because the adenomyosis can be associated with a lot of peritoneal endometriosis, and you may have raised CA125 levels in adenomyosis also. Okay. LDH not that superbly beneficial. You will have increased values of LDH. Okay, but that is predominantly due to the heavy amount of muscle inside. Okay, but I don't know how much it will practically benefit. See the point which you mentioned about 3D ultrasound versus MRI. Now, I think I'll answer it in this way. See, I think, okay, in good hands, a 3D ultrasound is going to give you much better information as compared to an MRI. But the most important word is good hands, and then the second word is good machines. Okay. Uh, See, if I can tell you openly that Visma is a much better ultrasound person compared to me, right? Because though I have taught him, I'm sort of proud to say that he is doing so much better ultrasound than me. All right, because my learning curve has probably stopped as far as ultrasound is concerned, because I hardly get time to do an ultrasound anymore. But I mean, you can expect Vismay to give you much more clarity on adenomyosis in ultrasound when he does it, okay, compared to when I am doing it. So I think that is the difference of having a good person doing it. And in a good person's hand, I think 3D ultrasound is better. See, otherwise, blanket rule is people will say, yaar, I don't have a great ultrasonologist, so I'll do an MRI. But the big problem about MRI, or I'll think the easy thing about MRI, okay, I'll talk it that way, is that try to read the plates on your own. See, you don't have to go into all those different types of modes, what is diffusion weighted imaging and what is this and what is that. You just have to look at the uterus. No, why are we worried about what is happening in the abdomen, right? So if you start reading these MRI plates on your own, no, I personally think that you will become good at interpreting MRIs also. Basic interpretation. I'm not talking of advanced interpretation. So the answer would be, if you have a good ultrasonologist and a good machine, then 3D is definitely better. Otherwise, do an MRI, but then try to get into a small habit, though it's a tough habit, but try to get into that habit of evaluating the MRIs at least basically on your own, is what I think. I don't know. Wait. I can. Please unmute Dr. Arti.
Right. Jay, now my next patient is again, we may again cross our time.
No, we are done 30 minutes,
Yeah,
madam.
I think, we'll do this the next time. But I just want to show one video, because you spoke about a hysteroscopic myomectomy, adenomyomectomy. So
Yeah.
patient would be an ideal candidate for that particular surgery. Jay, what is your opinion? Because you spoke about it, I want to drive home that image and the right surgery.
Can you share your screen and play that video?
It's on. I have shared my screen.
Okay, yeah. Sorry. Got it.
Yeah. So can you see that?
Yeah. I can see that. Yeah. See, I'll tell you honestly, this is very similar to an accumes, what you have just
Right.
Or people like to call it cystic adenomyoma.
Right.
It is completely enclosed. Fortunately, it is also impinging on the uterine cavity, and it is going to be very easy to operate this hysteroscopically. I just have one important pointer here.
Right.
See, please be careful, because what will happen is the minute the cavity opens, this cavity will collapse. Okay, the fluid in hysteroscopy, the circulation of fluid in hysteroscopy will ensure that the cavity will collapse, and you will not be able to take out the entire lining of this cystic adenomyoma, and the patient will have a recurrence. That is the commonest cause of patient having a recurrence, and which is the commonest patient we operate. Okay, so what one must do is, one must not cut on the adenomyoma. See that itch of cutting, no? The minute you see it is too intense, you know. So apply some itch guard over the hysteroscope and put it inside. You know, what will happen is you will not end up cutting it. Cut everywhere in the periphery, mark it. I'll show a Facebook live on this because we very routinely operate this. Mark that thing. Mark that thing so that even if it gets cut, you know how much to excise. And now I'll give you a beautiful counter. Here you are going through the endometrial cavity, no? So what has happened to the cavity now? Okay. In this adenomyoma, cavity will get injured, no? Or damaged, no?
Absolutely.
God will heal this cavity, yeah. So then don't be worried about laparoscopic adenomyomas also. Okay.
Right.
But keep that in mind, okay, when you are doing this surgery.
Super. Thank you. Thank you, Jay. That was a wonderful, practical and insightful session and lots of take homes. And I think our sessions on adenomyosis is not going to end so soon because there's so much to discuss, so much to learn. And next class also, we will continue with another case on adenomyosis. Thank you to all our 400 plus colleagues who joined us for this session. And very good night. Any points from your end, Jay, you want to say before we end the session?
No. It was great. I mean, see,
Right.
most of these sessions, I'm again saying, I'm just speaking what we normally do. So there could be some papers with, 4 cases which are published, which could have something different than what we have spoken. But then this is the practical experience which we have. And I hope these practical experiences which we are sharing, they help you, right?
Right.
Shilpa madam, you want to add anything?
No. I just want you to eat your dinner and sleep. Thank you so much for your time.